Hello everyone, this is Dr. Gopi. Today it is session 3 of ICU Nursing Orientation program and the topic is vital signs, early warning score and assessment. So we can catch the patient's worsening trend or deterioration even before it happens if we score the patient warning score appropriately or if we track the patient's vital signs appropriately. So why this matters? So vitals saves lives. So as you say, whenever the heart contracts, it forms in two forms: one as a pulse rate, the number of beats per minute, and as a pressure, the output of the heart functions. So here, around 80% of cardiac arrest shows abnormal vitals in the preceding 6 to 8 hours before it happens. Around 4 to 6 hours of average warning window before the clinical deterioration. If the new score 2 of more than or equal to 5 triggers an urgent clinical response. If the new score of more than or equal to 7 requires critical care team review. So the ICU nurse is the first line of defense. You see the patients minute by minute. You spot the trend that the monitor alarm misses. Trust your assessment. Act on it. Escalate early. So every hospital must have a process to identify and respond to the deteriorating patients as per the NABH 6th edition. So the learning objectives of this session is to measure the vitals accurately, correct technique for heart rate, BP, respiratory rate, SpO2, temperature and conscious level assessment should be properly assessed or measured. Calculate news too confidently. So each parameter has its own importance and we'll see how it varies from 0 to 3 as per the severity varies. Perform a head-to-toe assessment of patients. It involves A, B, C, D, E approach plus system by system review at every shift handover. And spot the deteriorating patient, identifying the early flag signs, escalate it to the right authority before the patient crashes to save the patient's lives. 6 core vital parameters. There includes what we are doing everyday basis: the respiratory rate, BP, temperature, heart rate, saturation and conscious level. Let's go deeper into each of one of them. So respiratory rate, how will you calculate? So you have to count for the entire 60 seconds. It is the most underdocumented vital. It is very easy to fake. So people just calculate for 10 seconds and then multiply it to 6 without watch quietly without alerting the patient and assess the patient's respiratory rate thoroughly. Regarding the BP, systolic and diastolic and MAP. So normal systolic should be more than 110, MAP should be more than 65. We should make sure the cuff size is appropriate and the bladder of the cuff, when you look at the cuff, inside it there will be a rubber bladder. It should be at least 80% arm circumference. It should be at least 80% of arm circumference. And arm at the heart level, recheck if first reading is abnormal. Regarding the temperature, the normal range is 36 to 37.5 degrees centigrade. The core temperature preferred in ICU, they are calculated from esophagus, bladder or pulmonary artery catheter. So tympanic and axillary are acceptable. The trends matter more than a single values. Regarding heart rate, the normal is between 60 to 100 beats per minute. Apical pulse for irregular rhythms. Don't rush the monitor blindly. Palpate to confirm. Regarding the saturation, normal is more than 96%. In COPD patients, we may have a target of 88 to 92%. There is a good reason behind it. Please comment below if you know it. And probe on warm, well-perfused digit. Remove nail polish. Wait for stable taste. And there should not be any transient changes in the saturation waveforms. And regarding the conscious level, ACVPU measurement is used. The normal is alert, the first description of the ACVPU. The remaining terms explains into confusion, voice, pain and unresponsiveness. The common errors in vital measurement. So avoid these errors that is being done in ICU. on a regular basis, counting the respiratory for only 15 seconds and multiplying it into 4. So if in case of irregular breathing, you may miss some of the respiratory rapid breath or slow breath if you count very short period of time. Count for a whole 60 seconds. The charting by exception or copy pasting. So each set of vitals is independent. Charting same number shift after shift is a red flag. Ignore single parameter score of 3. So if as per the news 2, if there is any single parameter scoring more than 3 is a trigger for escalation. So you should not miss it. Using adult cuff on a slim arm, match cuff to arm. Oversized cuff may give a falsely low BP. So undersized results in falsely high BP. Trusting SpO2 in cold or shock digit. So poor perfusion may result in unreliable reading. So try ear loop or check trace quality, or just take an AVG in case if you're really doubtful and if it is really life threatening. And documenting after the rounds. So document at the bedside in real time. Delayed entry loses accuracy and is medico-legally risky as well. So regarding the news 2 scoring chart, so we are looking at a tabular column here. Here we have what all the parameters to be considered to calculate the news 2 scores, and each parameter have a range from 0 to 3 value. So 0 is normal. As the number increases, the severity increases. So all the respiratory rate, SpO2, air and oxygen, systolic BP, pulse, conscious level and temperature normal value is 0. Once it deviates as the severity increases, then we are going up with the score. Here, for example, if you see 12 to 20 is the normal respiratory rate. If it is going beyond 20 to 24, it is Muse 2. If it is more than 25, it is Muse 3. And if it is going on the lower side, bradypnea 9 to 11, it is 1. So if it is less than 8, it is 3. Regarding SpO2, if it is more than 96, normal. 94 to 95, it is 1. 92 to 93, 2. Less than 91, it is 3. So as you see in this calculation, we have to calculate each and every parameter at the time of admission. Based on that, we will calculate the patient's severity, and each parameters of any 1, 3 is also a trigger for escalation. And if there is supplemental oxygen, add 2 and use scale 2 for confirmed COPD. The target SpO2 is 88 to 92. So news 2 response threshold. The 0 is low risk patients. So monitoring is minimum 12th hourly. Continue routine monitoring. The Muse score between 1 to 4 is low medium risk. Monitoring is minimum at least 4 to 6th hourly. Inform nurse in charge, reassess and decide on frequency increase. 3 in any single parameter. It's a single most trigger. It is commonly ignored as well. So these kind of patients needs minimum hourly monitoring. So urgent review by ward-based clinical team and do not wait for total to rise. And news score between 5 to 6, it is medium level of urgency. Monitoring minimum hourly and urgent review by clinician with acute care competence. Consider escalation to critical care. And more than or equal to 7 Muse 2 score is high emergency. Here we need continuous monitoring, and emergency assessment by critical care team should be made immediately and likely transferred to higher level of care. Consider code blue if the patient is in peri-arrest period. ICU assessment, the ABCDE approach. It's a systemic reproducible done at every shift handover or after any deterioration or any improvement. The airway, whether it is patent, ET tube in position or not, what is the cuff pressure, what about the secretion levels, and how about the patient's voice. These are the red flags. If there is any stutter, gurgling, unable to phonate, or ET cuff leak. Regarding the breathing, the respiratory rate, saturation, chest expansion, symmetricality, and breath sounds, accessory muscle use, and ABG trend. The red flags includes respiratory rate less than 8 or more than 25, or saturation less than 92, the paradoxical breathing or silent chest. Regarding circulation, the heart rate, BP, MAP, CRT, the peripheral temperature, the urine output, lactate, and ECG rhythm. The MAP less than 65 millimeters of mercury or lactate more than 2, urine less than 0.5 ml per kg per hour, or cold peripheries, new arrhythmias. Regarding the disability, ACVPU or GCS, pupils, glucose, focal deficits, RAS sedation score. The drop in GCS more than or 2 values, or new pupillary asymmetry, or glucose less than 70 or more than 250, or red flags for disability. Regarding the exposure, full body check, wounds, drains, lines, rashes, pressure areas, temperature, and cough. The new rash, bleeding, hot or swollen cough, missed pressure injury, and line erythema are the red flags. Recognizing the deteriorating patient. In a subtle way, the patient may be restless or unusually quiet, mild increase in respiratory rate between 18 to 22, small drop in BP, still in range, decreased urine output trend, family says he doesn't look right. In concerning case, the news 2 score may be 5 to 6 or single parameter score of more than 3 is equal to 3, and new confusion or agitation, saturation falling, needs more oxygen. The patient may be cold or mottled peripheries, lactate rising more than 2 millimeters of liter. Critical and act now case, the news 2 score may be more than or equal to 7, the drop in GCS more than or equal to 2, and unresponsive. The silent chest, paradoxical breathing, saturation with the systolic BP of less than 90, and no urine for more than 4 hours, peri-arrest signs like bradycardia or gasping state. So how this session maps to NABH 6th edition. So uniform care to patient. The ICU assessment must follow written guidance applied consistently across all settings. Every nurse uses the same method of ABCDE plus news 2 score. And PSQ method, hospital must have a defined process to identify and respond to the deteriorating patients. News 2 and EWS is the recommended tool. Medical record documentation. Every vital sign must be signed, dated, and timed. Chronological order maintained. Initial and periodic reassessment that includes documented initial assessment within defined time frame, typically 30 minutes from ICU. Reassessment frequency based on patient's acuity and news 2 levels. Staff training and competency. Nurses must be competency assessed in vital sign measurement and early warning score calculation. Training records maintained. Care of the critically ill patients. ICU specific protocols for continuous monitoring, escalation, and family communication during deterioration. Let's go through a case scenario. What would you do? Work through the scenario with your trainer. The patient, Mr. R, 68 years old, post-op day 1, abdominal sepsis on nasal cannula 4 liters per minute O2 in bed number 5. At 2 p.m., your vitals are respiratory 24, saturation 94 on O2, heart rate 118, BP 102 by 64, map of 77, temperature of 38.2 degrees centigrade. And the scoring shows alert but a bit drowsy. Urine output last 2 hours 25 ml. Step 1. Calculate news 2 for respiratory rate score 2, saturation score 1, on O2 score 2. By calculating all the things, the total news 2 is risk 9. It comes under high risk. Step 2. Your action should be emergency assessment should be made. Critical care team review immediately. Place on continuous monitoring. Call resident now. And think of sepsis, Q SOFA, calculate, check lactate, blood cultures, and antibiotics. Increase O2 as needed, prepare fluid bolus, and hourly urine output, strict monitoring. Document news 2 time, who called, response received, and repeat vitals in 15 minutes. So key takeaways from this session includes count respiratory rate for full 60 seconds. It is the most sensitive predictor and most ignored predictor of deterioration. News 2 score more than or equal to 5 is equal to urgent clinician review. News 2 more than or equal to 7 is equal to emergency critical care response. A single parameter scoring 3 triggers escalation even if the total news 2 is low. Use the ABCDE framework for every shift handover. Document red flags. Trend matters more than single readings. Look back 12 hours, not just the last set. Your gut feeling is data. Escalate early, escalate often. Better safe than sorry. These are the quiz for the session. Just take a screenshot or pause the video here, and I'll be waiting to see your response in the comment box. So the next session will be session 4 regarding the ICU documentation and March chart compliance. We will cover NABH 6th edition IMS chapter and the 10 hours of medication administration, and the new inclusion of medication safety officer and digital prescription requirements. Thank you. Bye. Signing off, Dr. Gopi.